welcome back to the Leukopak Lady. In the previous episode, I explored how the first mile can influence the choice between centralized and decentralized manufacturing of cell and gene therapies. Today, I'm diving deeper into the real-world trade-offs between these models and exploring how the first mile plays out differently depending on the therapy type, logistics, and patient needs. Let's start with an example of centralized manufacturing in action. This model is widely used in early clinical development and for highly complex therapies like CAR-T. A great example is the original Novartis Kymriah manufacturing model, which relied on a single site in New Jersey. Patient cells were collected globally and shipped there for processing and then sent back to treatment centers. So why does this work? Centralized sites allow for strong control over quality systems and regulatory compliance. Staff are highly trained and process changes are easier to implement at scale. This is especially useful when the manufacturing process is highly technical or still evolving. But remember that first mile? In this model, it's complex. Patient cells may be shipped across continents, requiring robust cryopreservation and cold chain logistics. There's an increased risk of delays or loss in transit, especially for autologous therapies where timing is critical. In addition, chain of identity becomes harder to manage across long distances. Now let's contrast with decentralized manufacturing. Emerging cell and gene therapy companies are exploring decentralized models, particularly for therapies that need rapid turnaround or involve less complex processing. Some hospitals are even performing point-of-care manufacturing for early phase trials. Here's where the first mile improves. Cells are collected and manufactured within the same region, or even at the same hospital. That reduces transport time, increases material freshness, and may even eliminate the need for cryopreservation entirely. For autologous therapies, it allows for greater flexibility in scheduling around the patient's condition. But there are trade-offs. Skilled staff are difficult to find across many manufacturing locations. Quality control becomes more difficult to standardize across multiple sites. Regulatory burdens multiply. Each site may need its own licensure, inspections, and documentation. And while both the first and last miles get simpler, the consistency and scale-up challenges of the manufacturing process increase with a decentralized model. So which is the right model? It still really depends. Autologous therapies often lean towards decentralized models when speed is critical and local infrastructure exists. Allogeneic therapies, where donor cells are processed into off-the-shelf products, tend to favor centralized models because scale and consistency are more important than speed to bedside. Some companies even use hybrid models, centralized processing with regional cryopreservation hubs, or decentralized collection with centralized final fill and release. So the first mile isn't just a logistical detail, it's a strategic consideration that shapes manufacturing choices, timelines, and ultimately patient outcomes. In the coming years, we'll likely see more innovation, not just in the therapies themselves, but in how we manage the movement of cells, both at the start and the end of the journey. Thanks for watching, and I'll see you next week on the Leukopak Lady.